Good afternoon, everyone. My name is Edward Shabang, a mental health nurse based in Babane Government Hospital, the psychiatric clinic. So let's talk about antipsychotics. I understand a lot of MOs, they don't like this part of psych, especially because it deals with behavior. Behavior is about a story, what you do. So they don't like stories. They don't like listening to people talk, probably. But unfortunately, the pandemic that comes with us, they have escalated mental health cases. So we are forced to focus onto mental health. So that's why it's good that today we are here to talk about antipsychotics. So we'll talk about the indications, the contraindications, side effects, also touch on the neuroleptic malignant syndrome, remind each other about the injectables, and then we look at the special considerations when prescribing. Look at the story, how long it is. So medical doctors, they don't like this. But this is about a 42-year-old male of around Babane. Is used to being admitted in the psych hospital. Like every year in December, they are admitted. The story behind that is it says most of the time he used his medicines, the chlorpromazine he's getting, the pills. He used it to drug other people in town when they are in the alcohol drinking spot. So he used it, he abuses it actually. So now he comes in a state of relapse, seeking help. Jumps the line, is shouting, verbally aggressive. Fortunately, the nurse comes out to request that please come this side, let's take the injection. The medication is no, 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 I don't want the injection. I want my CPZ, my chlorpromazine, because he knows where he wants to use it. Unfortunately, because of the fighting, the shouting, security officers comes in. They ask what is happening. The nurse there requests that please bring more security. When they came, he asked again, can we give you an injection, Mr. Sabelo? Because of the presence of security, he was afraid of what will happen to him. He agrees to take the injection. And because he abuses the chlorpromazine, the nurse decided not to give chlorpromazine again because obviously he's going to default taking that medication. Then he gives risperidone, 2 milligrams, and then benhexol, 5 milligrams PO. So antipsychotics, they can fall into different groups of drugs. Sometimes they are called major tranquilizers, sometimes neuroleptics, sometimes psychotropics. We have typical and atypical, first generation and second generation. As Ms. Lin has told us that in the first generations we have haloperidol and chlorpromazine, but second generation, that's where we have most of the sulfide, risperidone, olanzapine. So antipsychotics are indicated for many conditions. It's not just schizophrenia. A lot of people, they like the word schizophrenia. They are indicated for many psychotic conditions. When we speak of psychotic conditions, we're speaking about a person having delusions, having hallucinations, could be hallucinations in the five senses: visual, auditory, olfactory, gustatory, and so forth. So there are a lot of uses. There are other uses which are medically oriented, like in the Tourette syndrome, in the case of neurology, tics, they are treated with antipsychotics. Anorexia nervosa, obsessive compulsive behaviors or disorders, nausea and vomiting. We have seen a lot of doctors prescribing haloperidol for hiccups. But we cannot talk about antipsychotics without talking about the blood-brain barrier. A blood-brain barrier is just a specialized cell. The body is made in such a way that it protects the brain from harmful toxins in the body, harmful chemicals. So it makes uses of the blood-brain barrier where uh, blood that circulates in the brain is separated from blood that circulates out of the brain and out of the spinal cord. So it's a way of limiting toxins affecting the brain. That is why antipsychotics takes time to have their therapeutic effect when you take them. That is why you cannot take antipsychotics for a week and you are okay. You have to take them for longer because of this barrier. So antipsychotics are contraindicated where there is hypersensitivity. Of course, every drug is contraindicated in that. In Parkinson's disease, because it can make it worse with its side effects. In glaucoma, in peptic ulcers, CNS depression, elderly patients. Why is it contraindicated in elderly patients? Anyone with an answer for that? Elderly patients. Why do we say it's contraindicated? A lot of elderly patients are having psychiatric conditions, but we say here it's contraindicated. Most of our elderly patients, they have comorbidities. Uh, some interactions of the drugs can be a reason. Also, because they are very frail, we say they are like our kids, they are like children, very sensitive. Some of the side effects of the medication will be masked by the condition that they of development that they are in. So let's talk about the side effects now. How do we manage them? First of all, it's important to reassure your patient when it comes to you with side effects, especially because it's an overwhelming kind of situation. They are panicking as to what is happening to me. Then you do your mini mental status examination, but mainly you assess the symptoms and the severity of the side effects. Then if the side effects are not too severe and the patient is mentally stable, what can we do? We just reduce the dose of that antipsychotic. Remember, there is a risk of relapsing. We are reducing because the patient is mentally stable. Then we can also prescribe anticholinergics at a low dose. Then what if the patient is unstable and the side effects are very severe or they are not severe? In that case, you just have to change to a newer antipsychotic. Although both newer and older are effective in a similar way, but we understand now that the newer ones, they also have an effect on serotonin, and they are milder in terms of side effects. But we can still give anticholinergic drugs there. Then the side effects that are caused by antipsychotics are so many, and we cannot just give anticholinergics. We don't give R10 for every side effect that is possible. So it's important to know the non-pharmacological part of management for side effects. Like in the case of dry mouth, you can advise for a sugarless candy, ice cream, ice cubes inside the mouth or sips of water and do oral hygiene. That is if it's not very severe. In cases of blurred vision, which subsides within a few minutes, you advise the patient not to drive and to clear their pathway at home. Remove small items along the passages where they usually mobilize or go. In cases of constipation, increase the fluid intake, advice for hyper diet, And physical activity, it's very important. Urinary retention, you monitor intake and output, advice for warm baths, also advice for pelvic exercises. Another thing to do is to allow the patients to wash hands in a sink. Has anyone heard of that? Yeah, it just triggers the urge to urinate. In cases of GIT problems like nausea, you just allow patients to take fruit juice and not take concentrates as they are, but let them be diluted. In cases of skin rash, uh, avoid contact with liquid concentrates. You also have to treat the skin condition, or if it's severe, you change the drug, especially in adolescents because they are very peculiar about how they look. Their skin is their primary, it's what they use to appear in the community. It means a lot to them. In cases of sedation, you just prescribe a Noctare doses. And then you advise that they should not drive or work while they feel drowsy or when they're using sedatives. And ask them not to use energy drinks to try and counteract sedation because they also have a lot of side effects. In cases of orthostatic hypotension, it's hypo. Sorry. Just advise them to rise slowly from any lying or sitting position and then monitor the BP. In cases of photosensitivity, let them wear protective sunscreens or clothing, or they work under shade. Put anything to cover them when they are outdoor. In cases of weight gain, you have to weigh the patients to see how much weight they have gained and also educate about diet and exercise. Other side effects that can appear would be sexual dysfunction. I remember in our clinic we have one man who came to us to say, I am impotent now, but I'm not complaining about that. I like it. So he said, please do not treat that. I don't know why he said that. I don't know the situation at all. But it's one of the side effects. Then there are extra pyramidal side effects, which include pseudo-Parkinsonism, which is the tremors, the shuffling gait, the drooling, the rigidity in the muscles. There is also akinesia, which is stiff muscles, facial freezing, the stupor. Anyone who has seen a stupor? It's like a freezing robot. They just pause in one position for a long time. So the muscles, they just lock the movement. There is also akathisia, which is continuous restlessness and fidgeting. They are restless in the legs and hands, as if they are anxious. Dystonia, muscle or spasm twisting. I once saw a patient while I was still a student who was always walking like this. I didn't understand what was happening, but now I understand it was dystonia. Tardive dyskinesia, which is involuntary facial or jaw, tongue, lips movement. Uh, let's see if I can play this. It's not playing. It's not playing. I think we'll play it later. So let's talk about the neuroleptic malignant syndrome, which is one of the side effects of anti-psychotics, where the patient will be sweating a lot. Uh, their excuse me, limbs will be locked probably in one position. Sometimes there will be hyperplexia. They will be grinding teeth. Their movements will be very difficult. They will be restless. Sometimes they will be vomiting. So many patients do have this, but they don't know why they are having it. And most of them, they don't come in time in hospital. They come in a very severe kind of situation. So how do we treat this neuroleptic malignant syndrome? We just stop that drug, which is a causative agent. Then we aim to normalize vital signs. We treat supportively, especially because there are medications that are able to treat it, but they also have side effects. So if possible, we avoid them, we just treat symptomatically. Then in the issue of having long-acting injectables, we consider them only as adjuvants in cases of resistance, where you're trying to treat but there is no positive response, and when patients are defaulting their treatment. So we have the flufenazine, which we call Modicate, and we start from a lower dose, probably 12.5. Then we can titrate it up. It's preferred for violent and restless patients, and it has that depressant effect. Because maybe of the side effect, it locks the movement. When they have the positive symptoms, it calms them down. We also have the flupentixol, which we call fluanzol, available in 20 milligrams vials, but we can give up to 80 milligrams in 2 weeks or per month, depending on the response from the client, and we can titrate within 2 or 4 weeks. That one, it has an antidepressant effect, and so we give it with caution in bipolar patients because it can lead to mania. Then you have to understand that for all injectables, we have to give the aten because we want to prevent the side effects. But when we give the orals, you don't have to give the aten all the time. Give the aten only when the side effects appear. So all antipsychotics, they can lower the seizure threshold, but in different levels. The most prominent culprit is chlorpromazine. So it's important to prescribe with caution in people living with epilepsy. And because chlorpromazine can also cause postural hypertension, you have to monitor the BP. And then when we are dealing with children and elderly, pregnant and breastfeeding women, it's very important to consult with the psychiatrist. As Ms. Lynn has told us that there's no single antipsychotic which is safe in pregnancy and in breastfeeding and in kids also. So you always start with one antipsychotic drug when you're prescribing. You start with a low dose until you reach that therapeutic range where you see subsiding symptoms of psychosis, which usually happens within 4 to 6 weeks. So if you say, I'm giving chlorpromazine and chlorpromazine is working, can you say it's not working within 1 week? No, you cannot say. You just have to titrate it up. Then if you have reached your maximum dose in 4 to 6 weeks, then you can say it's ineffective and you can change to another one. Then the issue of sulpride, it's almost the same as the fluanzol. It also have that smaller antidepressant in it, so it can induce mania in bipolar patients. So we don't have to give anticholinergics in every side effect. As I have mentioned before, that we have to treat them without using drugs. Let's treat side effects without using drugs to avoid polypharmacy. So also we have to monitor the weight, the BP, FPS, especially when prescribing olanzapine and risperidone. And then we avoid olanzapine and risperidone in the obese, diabetic, elderly, and hypertensive patients because it can make their situation worse. So that's the end of part 1.